This podcast has been sponsored by Salix Pharmaceuticals. Maintaining a healthy gut is key for overall physical and mental well-being. Whether you're a health-conscious advocate, an individual navigating the complexities of living with GI issues, or a healthcare provider, you are in the right place. The Gut Health Podcast will empower you with a fascinating scientific connection between your brain, food, and the gut. Come join us. We welcome you. Hello, friends, and welcome to the Gut Health Podcast. We are your hosts. I'm Kate Scarlatta, a GI dietitian.
And I'm Dr. Megan Reel, a GI psychologist. This episode is part of a two-part series on irritable bowel syndrome with diarrhea predominance, also known as IBS-D. And Kate and I love to do these mini-series to give you a slightly shorter chunk of time as well as information. So you can tune into this maybe while you're sitting in your gastroenterologist's office, thinking about what am I going to say, talking about my diarrhea, or maybe it's easy for you to just pop it on your morning commute. So we love that you want to listen to our longer episodes, but this is going to be a little bit shorter, but still chocked full of really good information.
Totally agree. And, we asked our listeners what they prefer, and it was really a mix.
Yes.
So this way is a nice way to meet the needs of those that like the shorter little clips. So we got you. We got you. So today we're going to get into the weeds of IBS-D, including causes, triggers, and treatments. So let's introduce our expert guest today. Anthony Lembo is a nationally recognized gastroenterologist and clinical researcher specializing in gastrointestinal motility disorders, particularly irritable bowel syndrome. He is a professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and serves as vice chair of research at the Cleveland Clinic Digestive Disease Institute. Dr. Lembo previously spent more than 2 decades right here in Boston with me at Beth Israel Deaconess Medical Center, where he was director of the GI Motility Laboratory and a professor of medicine at Harvard Medical School. Over the course of his career, he has been really a leader in advancing the understanding and treatment of IBS, chronic constipation, and related functional GI disorders through clinical care, translational research, and pivotal clinical trials evaluating new medications, diet therapies, and supplements. Dr. Lembo continues to care for patients with complex motility and functional bowel disorders while leading innovative clinical research aimed at developing more personalized and effective treatments for IBS and related conditions.
Well, we are going to dive right in. So, Dr. Lembo, we're going to start with what is IBS-D, and then just a few of those alarm signs when maybe it's more than IBS-D.
Well, thank you, Megan. Yes. So IBS-D stands for irritable bowel syndrome with diarrhea. So diarrhea is exactly what most people think of. It's generally someone with loose stools. We quantitate it using what's known as the Bristol Stool Form Scale, which is a way for people to speak the same language. So if you have very loose stools that are somewhat unformed or very loose that is completely unformed, you'd fall into the upper ends of the Bristol Stool Form Scale. It's a scale from 1 to 7. That would be a 6 or 7. And if most of your stools tend to be loose, watery, and we quantitate it by being more than 25% of the time, and not having hard stools for more than 25% of the time, you would fall into the diarrhea classification. IBS, of course, has abdominal pain. It can also have other abdominal symptoms like discomfort or bloating. Has to be present for at least 3 months, having those type of symptoms with an onset of at least 6 months. And the frequency has to be sufficient to meet the criteria for IBS. And importantly, the most important part is that the abdominal symptoms have to be associated with the bowel habits. So either the pain's related to bowel movements, the frequency, the change in stool frequency, or a change in stool consistency. So that could be the definition of IBS. Now, typical Rome 4 definition, and there's a new Rome 4 that's just coming out that'll be similar. The frequency will change, and it'll also have more abdominal symptoms will be allowed with it. The other part of your question was about alarm features, because of course those symptoms are very common in the population. The longer you have it, and that's one reason why we have the 3 months of these type of symptoms and the onset for at least 6 months, it's less likely to be due to other causes. So first of all, I want to make sure that it's frequent enough, because if I have diarrhea from a gastroenteritis, it'll just tend to come and go. It doesn't usually linger on for most people. And then we look for other causes that could explain it, of course, because there are other causes for chronic symptoms. And the most common ones that we see in the United States would be like something like celiac disease. So we know that somewhere between around less than 5% of the population that have IBS symptoms would have celiac disease, but that's still fairly common. So it is recommended that you be tested for celiac disease if you meet the criteria for IBS, and it can be done with a simple blood test. So a TTG, which is an antibody test that we can offer, and so it's fairly easy to get. So we want to make sure you don't have celiac disease, which would probably be one of the more common things to look for. And then, of course, inflammatory bowel disease would be the other, particularly Crohn's disease, because ulcerative colitis, which those are the two types of inflammatory bowel disease. Ulcerative colitis tends to present with bleeding, which would be an alarm symptom, which I'll talk about in just a minute. But we would think about Crohn's disease, which could mimic IBS, and that can be diagnosed by a simple blood and stool test. Those stool tests looking for inflammatory markers. And if you have a negative stool test that's really normal, the odds of you having inflammatory bowel disease would be quite low. We look for other things like bile acid malabsorption. So if someone's had a gallbladder taken out, they may be prone to having increase in bile that occurs. So typically bile is released after a fatty meal and mixes in with the fat, helps us to digest it. But someone who's had a cholecystectomy or a gallbladder removed, they'll release bile so throughout the day and also into the night, and that can tend to overwhelm the system because it's reabsorbed in the distal bowel. And when bile gets into the colon, it can cause diarrhea. So we think about that. Microscopic colitis would be another. Malabsorption for like lactose or other types of malabsorption can certainly cause it. And chronic infections, the most common in the United States, the one we generally recommend, particularly if they're risk factors, would be looking for Giardia. So again, that can be pretty easy with a stool specimen. So when we evaluate someone, we tend to look for what we call alarm symptoms. So this is we always tell people, if you're having any alarm features or symptoms, please let us know, because even though you may not have it today, you may have it later. And as I've already mentioned, blood in the stools is probably one of the more common symptoms that could suggest an organic disease, such as ulcerative colitis, as I mentioned, also cancers, which would be extremely rare with chronic symptoms, but something to consider. We also think about unintentional weight loss. So if someone says that they've lost more than 10% of their body mass, but that they're not trying to lose weight, then you sort of think about it. New onset over the age of 50 or 55, that can be considered an alarm feature. IBS tends to start at a younger age. Of course, it can start at any age, but just start to think about whether something else could be explaining it. If they have a low blood count, so someone shouldn't be anemic unless there's another explanation for it. So we do see a lot of young women that are menstruating that may have other reasons to have anemia, but you certainly want to look into it a little bit further. If someone has a family history of the things we talked about, inflammatory bowel disease, cancer, celiac disease, then you would probably do some additional testings to see that. But when you have the symptoms of IBS, particularly the chronicity of it, no alarm features, and some limited testing would include some of the diseases we talked about, so like stool calprotectin, which is that inflammatory marker I was discussing earlier, celiac disease, maybe Giardia, CBC for a complete blood count. Those are simple tests that we would tend to do in many people with IBS with diarrhea. If all those are negative, they don't have alarm features, the overwhelming odds are that you'll have IBS. In fact, probably over 99% odds that this will be irritable bowel syndrome. That was a long-winded answer to your question. I hope that was...
But comprehensive, and we appreciate that. And it's a good rundown to help give people a roadmap in what can feel like a really complex, and it is a complex disease.
Absolutely. And you don't want to miss any of those alarm features. So seeing a gastroenterologist or even a primary care doctor to really assess your diarrhea and any sort of other issues that might raise some flags that it's more serious. And then it's always important because IBS does have a lot of mimickers, and you really covered a lot of those that are really important. One you didn't mention, and maybe we'll touch upon that in a minute. And maybe, this is kind of new, is that sucrase isomaltase deficiency, So let's talk about that in a minute. But I want to jump into post-infectious IBS because we know that having a bout of foodborne illness can trigger an IBS scenario. What happens in the gut? Does something happen to the gut after this infection? And what are the odds that someone's going to have IBS for the rest of their life? Or is this going to be something that will eventually kind of work out of their system? What's going on with post-infectious IBS?
So that's a great topic because it is the one area that we have the most data for the pathophysiology, both the prevalence, et cetera, the epidemiology, as well as the pathophysiology that's been worked out for post-infectious IBS. But taking a step back, it's not just post-infectious, it's actually any type of inflammation in the gut has been associated with IBS. So it seems to be one of the major causes for IBS is an inflammatory event, whether it be an infectious, inflammatory bowel disease. A lot of patients, about 20 to 25% of patients, once the IBD is quiescent, will tend to have IBS symptoms. Diverticulitis, for example, there's been nice studies looking at the prevalence of IBS after that. So almost any chronic inflammatory event, and post-infectious or an infection event is one of them. It could be almost any type of infection. So it's been documented in post-viral, of course, bacterial infections, probably the best documented of them. Long before IBS was called irritable bowel syndrome, they used to call it post-salmonella bowel issues. Like they didn't call it irritable bowel, but post-salmonella syndrome. And they knew that people that had an infection, in that case was from salmonella, many of them would develop long-standing symptoms. And that, you asked for the number, well, it's about 10 to 15% will develop symptoms that will be long-lasting. And by long-lasting, we mean about 6 months. The good news is, as we follow these patients over time, and they've done this over 10 years, the rate does go down. And it tends to plateau somewhere around where the prevalence of IBS is in the population, which is kind of interesting, which has led one group to model this and show that this is probably one of the major causes of IBS. Now, we know IBS is a heterogeneous disorder. There are many different causes, but this is probably a big factor, again, in all types of inflammatory conditions. So what happens with post-infectious IBS? Well, we know that you get a persistent low-grade immune activation that occurs in the GI tract. What I mean by that is that if you do biopsies of patients that have post-infectious IBS, that you can measure an increased number of chronic lymphocytes. You can see also other types of cells, endochromatin cells, that will be increased in patients, and a change in permeability of the lining of the GI tract as well. And that in turn will cause an increase in sensitivity to the nerve. So we talk about one of the major causes of IBS being hypersensitivity, as well as alterations in the brain-gut interaction. So the way the brain processes those signals seems to be altered, particularly in the chronic patients. So all of these factors have been shown to occur in people with post-infectious IBS, and again, occur in many other people, even when we can't document post-infectious IBS. And there, in turn, there'll be changes to the microbiome that occur after infection, probably due to a number of factors, including changes in the motility that will occur. But again, the good news is the prevalence does go down over time. So I always tell patients that they're likely that the symptoms are probably going to be less severe over time, but it can be several years in the making.
I remember that one of our colleagues, Dr. Bill Che, taught me a long time ago about you can give patients with post-infectious IBS some hope because of that spontaneous recovery research that's been done, that, they may just get better. And so I like to bring that up with patients that that's possible.
Absolutely.
And I think it's probably worth just mentioning for the audience that there was a study that looked at the role of improving the permeability of the gut in patients with post-infectious IBS. And so what they used was an amino acid called L-glutamine and gave it to patients that had documented post-infectious IBS and increase in permeability. So it turned out to be about half of those patients that had documented post-infectious IBS. And they were able to show in that study, which obviously needs to be replicated, that improvement in the permeability correlated with improvement in their IBS symptoms. So I think there are some treatments, for IBS in general, but maybe even specific for post-infectious.
Yeah, I love that glutamine study. And I know there was a lot of research, even in IBD with glutamine a long time ago, back in my early stages of being a dietitian in IBD. Walter Willett at the Brigham and also at Harvard was doing a lot with L-glutamine. It's an amino acid that is really important for the gut turnover and keeping the gut healthy. It is interesting to see that it had some effects on that post-infectious IBS model.
Abdominal pain and diarrhea from IBS-D getting in the way? You may find relief with Xifaxan with an X. Xifaxan rifaximin is a treatment for adults with irritable bowel syndrome with diarrhea. Visit Xifaxan.com/IBS-D for the PI or talk to your doctor. Don't use Xifaxan if you have a history of sensitivity to rifaximin, rifamycin antibiotic agents, or any components of Xifaxan. Tell your doctor right away if your diarrhea worsens while taking Xifaxan, as this may be a sign of a serious or even fatal condition. Tell your doctor if you are pregnant, plan on becoming pregnant, are nursing, if you have liver disease, taking warfarin or other medications. Some medications may increase the amount of Xifaxan in your body. Most common side effects are nausea and an increase in liver enzymes. Xifaxan.
So let's just talk a little bit about CSID, because I know that this is something that you're very well aware of. And Bill Che and Brooks Cash have done some research looking at prevalence in patients with IBS-D and developing sucrase isomaltase deficiency. And I think this is really interesting and maybe tied into that inflammatory component that we see in these post-infectious patients. But I'd love your intel on this, because I don't think a lot of consumers or patients have ever heard about sucrase isomaltase deficiency. And it is an IBS-D mimicker that we're really just starting to really understand about. And this is more of an acquired form that we're seeing in adults, I think, with IBS-D, not the congenital form that you're typically born with and is quite severe. But can you elaborate on that?
Yes. I don't think a lot of clinicians are familiar with CSID. And CSID, of course, stands for congenital sucrase isomaltase deficiency. And as you said, for the adults, much of it's probably acquired, so we wouldn't necessarily call it CSID.
Right.
We call it SID. And the isomaltase is just because that's how it comes out. It has to be broken down. They come from the gene. It comes out as one compound, and then it's actually broken down. It's not as common as lactase deficiency or some of the other disaccharidase deficiencies, which I think most of us are aware of, and consequently most people are aware of. So I think for example, lactose, many people get symptoms, and then it's usually not a surprise to them, and they're very aware of it. For some of the other poorly digested small carbohydrates, for example, fructose, for example, I'd say less people are aware of it, but we know that large quantities of fructose can induce symptoms. Some people are not aware of it, and I think even fewer are aware of the role of sucrase deficiency. So sucrase, of course, is needed to break down the disaccharidase, and without it, when it's depleted, then you can get an increase in symptoms, just like you would with lactose or fructose or anything else that's not well absorbed by the GI tract. It causes an osmotic effect within the colon, and that in turn can cause gas and bloating because the bacteria will digest it and release these byproducts, which in turn cause more osmotic load within the colon, can cause bloating and diarrhea, etc. with it. So it's not just the sucrase deficiency, it's just the one that people are not aware of. So as you alluded to, Bill and others, and we've done this too, and when I was in Boston, looking at the prevalence of sucrase deficiency by breath testing, and Bill and others have looked at the role of biopsies and showing what was surprising to a lot of us was that it was higher than we really expected it to be. And now some studies have shown that people do not respond well to a low FODMAP diet, for example, may actually be deficient in this. And studies have shown that a small but a notable number of patients with IBS-D may also have some of the genetic predisposition towards having sucrase deficiency. So yes, I think it's an important area, one we need to be more attuned to. The treatment would be exactly the same as it would be for like lactase deficiency, first try to remove it. It's a little harder than lactose, though, because sucrose is found in a lot of different foods. And then, of course, like lactose, there's also a enzyme that you can take that can help digest the product as well, so you don't develop these symptoms. So it's an interesting area. And I did allude to lactose, but I was thinking more broadly.
Most definitely. I think it is much more prevalent, obviously, but I wanted to bring it up because I think I like these new novel research projects that are out there. And I think, it was like 7% of the people they studied, Dr. Cash and Dr. Shea, that had IBS-D. It was a pretty high number within that cohort of patients. So something to think about: sucrase isomaltase deficiency, not the congenital form necessarily, but more of an acquired form. And as Dr. Lembo mentioned, this is an enzyme complex that helps you digest sucrose, which is found certainly in our sweets and delicious ice creams and things that we love, but also naturally in some fruits and vegetables. And it also, because it has that isomaltase piece, there is some starch digestion that might also be affected in those that have that deficiency. So a little sidebar, but I think an important one, just put it out there, right?
That's right. Now, let's say we have the privilege of going to see Dr. Lembo in clinic, and I've got IBS-D. Dr. Lembo, talk to us a little bit about what treatment looks like. How do you decide diet, medications, behavioral strategies? Where do you go for patients? How do you begin?
It'll depend on the individual, depends what they've tried before and what type of symptoms they have. But usually we'll start with the simple things, which we call sort of lifestyle modifications, and that would include diet. And there would also include exercise and sleep, making sure that we maximize their lifestyle to the extent that we can. That'll be our first treatment, and we can talk more about the dietary stuff if you want to discuss that afterwards. But from there, we'll move on to slowing down the gut. So one of the first line agents would be a loperamide, which is a peripherally acting mu-opioid agonist. And so it stimulates that receptor, which we all know will slow down the intestine. And usually it's a low dose, and we'll just start at 1 or 2 tablets. Comes in 2 milligram tablets over the counter, and try to slow down the gut a bit. It doesn't tend to help the abdominal pain. So if a patient presents with more pain-related symptoms, we may want to add something to help with the pain. And that would be something like an antispasmodic would be one of the first agents. So here in the United States, we have several anticholinergic-based antispasmodic agents. Hyoscyamin and dicyclamine would be the most commonly used ones. And these can also be helpful for people with diarrhea because anticholinergic will tend to slow down the gut as well. And sometimes that combination, making sure that they don't become too constipated, may be sufficient. Peppermint oil would be an additional antispasmodic agent. It doesn't have effects on the bowel habits, but it can be pretty well tolerated. So we'll start with those medications. From there, we may add some prescription medications. And again, it'll depend on the predominance of their symptoms. So for example, if someone has predominant pain symptoms, we may add like a tricyclic antidepressant to reduce that hypersensitivity we talked about earlier. And tricyclics are known as neuromodulators. They work peripherally and centrally, and they sort of reduce the firing of the nerves, particularly the sensory nerves, so it can reduce the abdominal pain that someone may experience. If bloating is a predominant symptom, for example, then we may add some rifaximin, which is a poorly absorbed antibiotic that can reduce symptoms of IBS, including bloating, diarrhea, and abdominal pain associated with it. And that's a 2-week course of an antibiotic. It can be given 2 additional times based on the FDA recommendations. And from there would be other medications like eloxatiline is also an FDA-approved medication. It's a combined opioid medication, so it has some mu agonism and kappa agonism as well as delta. That combination has been shown, at least in animal models, to not cause as much constipation, but also reduce pain. And so that's led to it being approved for the use of an IBS-D. It's important, though, that patients who do not have a gallbladder or have excessive alcohol use, that would be defined as 3 or more drinks per day, don't take the medication because it can affect the biliary system and can increase the risks of sphincter voti dysfunction as well as pancreatitis associated with that. As a third-line agent, we may add a 5-HT3 antagonist, so that's a serotonin type 3 receptor antagonism, and that can help slow down the gut and reduce abdominal pain. The one that's approved for IBS with diarrhea in women is called elocitron, and it is associated with ischemic colitis, so for that reason, it's recommended only in women with IBS because that's where most of the studies were done, only after they've tried other therapies or failed other therapies associated with IBS. But actually, if you titrate the dose up, you can avoid the constipation associated with it, but still 1 in 1,000 may develop ischemic colitis. But it is readily reversible, although we don't like that to happen to people, but it is, I like to tell patients that it's reversible for them. So those are the major prescription medications. Of course, there will be others that we use occasionally, but those will be the major. And then, as you mentioned, we have the psychological treatments or behavioral type treatments, and those can be extremely helpful for all subtypes of patients. And it doesn't just have to be those with very severe disease, and certainly not those with severe psychological issues. It's not based strictly on whether you have anxiety or depression. We know that this disorder of the brain-gut axis is clearly involved in many patients. Doing this behavioral therapy can be very helpful, often with the psychologist, also through apps. And then Brennan Spiegel has shown that virtual reality can be used as well, and we hope to see more studies on that in the not too distant future. Cognitive behavioral therapy and hypnosis would be the 2 of the best studied behavioral treatments that we have available today.
Yes. So Dr. Lembo has worked with one of my esteemed colleagues, Dr. Sarah Ballou, in the past, who delivers those brain gut behavioral therapies, as well as I know that you've consulted with Kate on several patients from a dietary perspective. So, when you're living with diarrhea, a team approach is really the key. I also get patients that are anxious about remaining on these anti-diarrheal medications. Some of them feel like we're just putting a cork in it. And is there a problem with that? And so, what's the difference between kind of slowing digestion and then actually getting to the root and calming that overreactive gut?
So using a low dose loperamide, for example, which is the most commonly used mu-opioid, peripherally acting mu-opioid agonist, is safe at the recommended doses and can be used long-term. It's been out on the market for many, many years, and even before that, people were using it to reduce diarrhea. So it's going to be well tolerated, it's safe, they can use it long-term. I agree with trying to look for the root cause of it, and that's what we were talking earlier about bile acid malabsorption, the poor digestion, etc. There are other areas to look at, and some people even look at bacterial overgrowth, etc. And you can explore those different areas, but you really want to get the symptoms under control in patients. And when you don't find another treatable cause, which is by far the most common scenario that we see in our clinic, because again, it's probably this disorder brain-gut interaction. If it's a post-infectious etiology, you have a hypersensitivity occurring, you can treat it with tricyclics that may help, and obviously adding a mu-opioid would be very helpful for patients. And I think they can do it long-term. These are generally low doses and very safe.
We kind of talked a little bit about this, but we see it all in practice where patients get really into this panic mode of the root cause. And, naturopaths worried about cycle, learn something on TikTok, stress, am I cursed? How do we help manage that cycle and try to help get them answers, but at the same time, know when to kind of reel them in a little bit or avoid the chasing 17,000 gastroenterologists for their diagnosis and symptoms?
Yeah, I think that's extremely important that we give a confident diagnosis. There's enough literature, there's enough experience to tell patients that this is what they have. And yes, there could be some of these other etiologies that can contribute to their symptoms, but for the majority of people, it's a disorder of this brain-gut interaction, the way the signals are processed somewhere along the line from the gut all the way up to the brain. And there's no need, not doing a fifth CAT scan is not going to yield etiology. A third colonoscopy is not going to be appropriate for that individual. So I think, but it has to be the clinician that's confident on their diagnosis. I've been there, done that, I've seen that. You've had the appropriate evaluation. Let's move on to start treating you appropriately. Now, patients will have anxiety over this, and anxiety and depression are common in IBS and likely to do with some of the pathophysiology, at least some of the amplification that can occur in patients, because we do see it so commonly with it. But I think, I think you need to be confident. Now, for example, if I have a patient that has other chronic pain syndromes, for example, fibromyalgia, chronic migraines, etc., it's helpful to show them, look, this really is a signal or clear indication that there's altered processing of pain signals, most likely at that point up in the central nervous system area. So let's focus treatment on dampening that hypersensitivity. And that can be with behavioral therapy plus, the neuromodulators. And we mentioned the tricyclics. We'll use others like some of the SNRIs like duloxetine or even some other medications depending on the presentation of the patient. But probably the best tolerated would be the low dose tricyclics. At least that's what's recommended as first line for patients. So confidence is, I think, important.
Definitive diagnosis, confidence, and hope. And that is a pretty good recipe for getting people feeling better. So this was a fantastic talk, a very nice overview of IBS-D and strategies. And we're going to just really quickly get to know you very fast in a speed round before we let you go. So Dr. Lembo, if you weren't a gastroenterologist, what would you be doing with your life?
I was going to be an astronomer when I went to college, and I went to a small liberal arts school in Western Massachusetts that was very strong in astronomy, and I ended up taking a number of classes in astronomy, but realizing it was going to be hard for me to make a living doing that, and eventually found my way into medicine. So I probably would have been an astronomer.
I love that. That's a great answer. Okay, let's get into what is the biggest gut health myth that you want to bust?
That you have to have a bowel movement every day, and if you don't, taking laxatives is appropriate. That's not the way you see this advertised all the time, and that how you have a month worth of stool or 10 pounds. That's not true. So please do not take laxatives simply because you're not having a bowel movement every day.
Good one.
And what's something that instantly lowers your stress level?
Running in the woods. I love trail running. I spend much of my time doing trail running, less so in Cleveland, because I have to now drive to one of the parks. But where I lived in Boston, we had trails right out my back door. So I love doing that.
Yeah, I'm a nature girl. I like being out there too. So what's your hot take on probiotics? Yes or no for IBS?
Maybe. I do recommend them to some patients, but I tell them about the gaps in our knowledge for them. And we do it on a trial basis. Not long term. So I want to make sure that patients are not taking them, spending their money for years just because I recommended it, but as a trial to see if it helps them. I think we need better research. I know that's an easy answer, but we do need further guidance for patients with it.
And finally, do you like spicy food or are you a mild food guy?
Spicy all the way. In fact, I'll be stopping tonight to pick up some Thai food, and it'll be not heavy spice, but it'll be moderate.
That's perfect. That's perfect. Thank you so much for coming in, sharing your expertise. We are so appreciative. And for our listeners, please subscribe, like, and share the Gut Health Podcast.
And check out series number 2 coming up very soon.
Yes. Thank you.
Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can also follow us on social media at the Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends. Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can follow us on social media at the Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends.